Chairperson, and thanks for the invitation. I'm going to present the presentation of Professor Dr. Mustafa Mahmoud about delayed coil migration. Coil migration during coiling procedure is a known complication. However, delayed coil migration is relatively rare with potential neurological consequences. It may lead to serious ischemic events. Most of the cases are asymptomatic, and almost all of the cases of coil migration are incidentally discovered during routine CT or angiographic follow-up. The case I'm going to present is a 27-year-old male patient with diffuse subarachnoid hemorrhage and interhemispheric predominance. Angiography revealed ecom aneurysm with a neck width 1.8 millimeter. The patient was treated with simple coiling. The day following the treatment, a routine CT was done, showing a migration of the mass of coils. So the patient was transferred immediately to the angio suite, and we did a diagnostic angiography showing that the mass of coils migrated in the pericallosal artery. So we treated the patient with good packing to the ecom aneurysm. The patient was asymptomatic. Case reports or case series describing delayed migration of part or whole more coils were included. Cases where no frank migration in the parent artery or with bulge within the aneurysm neck were excluded. We reviewed all keywords of coil migration, delayed migration in PubMed and Ovid, and we discovered 28 cases with documented delayed coil migration. We had 20 cases, 9 male and 11 female patients. 6 aneurysms were located in the ecom, in the MCA, 5 in the PCOM, 2 in ophthalmic segment, 2 in the superior hypophyseal artery, 2 in the basilar trunk, 1 pericallosal, and 1 anterior choroidal, and 1 in the superior cerebellar, and 1 in the ICA termination, and in the anterior cerebral artery. We were not able to identify the neck width in 8 cases and the dome neck ratio in 5 cases. The average dome to neck ratio in 23 identified cases ranged from 0.9 to 2.1 millimeter with mean of 1.5 millimeter. The timing from the initial coiling to coil migration detection. There was a wide range of time from the initial treatment to coil migration detection ranging from 15 minutes to 1 year. Incidental discovered coil migration was noted in 16 patients, accounting about 75%. Those patients were completely asymptomatic and were diagnosed during routine CT scan follow-up. 12 symptomatic patients were included in this review. Symptoms were specified in 8 patients and were manifested between 15 minutes to 3 months. So the incidence of coil migration was identified in a study which found 0.3 risk of global intra-procedure or delayed coil migration. They included strictly whole coil migration and did not include migrated or reconfigured part of the coil. So what are the factors affecting coil migration? The first factor is wide neck aneurysm. The wide neck and small dome to neck ratio were 2 key factors. In this review, the mean dome to neck ratio was low. The use of balloon or stent during coiling theoretically should maintain the coils inside the aneurysm. However, in 10 cases in this review were treated with balloon assistant. The patient had coil migration, delayed coil migration. About partially thrombosed aneurysm, it also predisposed to coil aneurysm mismatch, as those aneurysms look smaller than the real size. Also, the underpacking, coil size mismatch, and aneurysm inadequately packed. What about the whorl flow? There might be possible role of the whorl flow and the high wall shear stress creating frictional force in the internal carotid and anterior cerebral location, predisposing to coil migration. Minimal coil protrusion might turn to coil migration. The use of a small diameter of coil with short length also may predispose to coil migration. What about flow-dependent aneurysm? Aneurysm subject to high flow from associated AV malformation may be liable to coil displacement. About asymptomatic migration, this could be interpreted to two mechanisms. The first one is the retrograde collateral revascularization in cases of obstructed flow by the migrated coils. And the second mechanism is the coils act as a stent-like conduit. What is the management of migrated coils? As I said, almost the cases are asymptomatic. The management depends on two main factors. The first factor is the occurrence of ischemia. The second factor is the degree of aneurysm occlusion following separation of one or more coils from the aneurysmal sac. So, to sum up, delayed coil migration is a rare but serious complication which may carry ischemic neurological consequences. Low dome to neck ratio, wide neck aneurysm, underpacking, the use of a small coil at the end of the coiling procedure may predispose to this complication. Endovascular treatment should be considered in urgent cases of significant symptomatic ischemia. Thank you.
Thank you, Dr. Wessam.